you very much. Becky, please unmute.
There we go. Can you hear me?
We can hear you, and make your screen full screen, please. Thank you.
There you go. Okay, like Dr. Jayaraja said, I'm going to be talking about cholangiocarcinoma. First, I'd like to thank both Dr. Zaromsky and Dr. Christians from MCW for their assistance with this presentation. And of course, Dr. Jayaraja, thank you for stepping in at the last minute. For the next 45 minutes or so, I will quickly review background epidemiology, anatomic classification, and some diagnostic workup. Basically, I would hope to spend the majority of the time discussing two cases reflecting the surgical and non-surgical challenges of this disease, specifically determination of resectability, survival data following resection, use of adjuvant therapy, and the role of transplantation. Please, I would like this to be as interactive as possible, so jump in, ask questions, and contribute commentary. So I think we're very fortunate because there are many of the institutions that are really pushing the limits of what is possible in the management of this disease here on this conference. So please contribute, and I know that I would appreciate hearing from you all. Cholangiocarcinoma is the second most common hepatic malignancy after HCC. It accounts for 3% of GI malignancies worldwide. The incidence in the United States is 1 to 2 cases per 100,000 per year, compared to greater than 2 cases per 100,000 in Asia. Thailand in particular has really high rates, as high as 113 per 100,000 per year. And as noted in the Nature review paper, the incidence is increasing in the West, although some of this may be artifactual due to changes in the classification of ICD-0. Common risk factors for cholangiocarcinoma include primary sclerosing cholangitis, choledochal cysts, cirrhosis, hepatolithiasis, liver flukes, and other liver toxins such as aflatoxin. Cholangiocarcinoma is divided into both intrahepatic and extrahepatic, as outlined here. Intrahepatic makes up 10% of the cases, and these typically arise above the second-order bile ducts. Extrahepatic cholangio is further divided into perihilar and distal, with the cystic duct really acting as the anatomic landmark. For perihilar cholangios, these represent about 60% of the cases, and distal is 30%. Within the category of intrahepatic cholangiocarcinoma, there are 3 main morphologic types: mass-forming, periductal infiltrating, and intraductal papillary. The mass-forming is the most common, accounting for 60 to 80% of ICCs. These are classically solid nodules that are distinct from the hepatic parenchyma. Periductal infiltrating, as the name implies, invades the parenchyma surrounding portal structures and is often associated with biliary stenosis. And of course, intraductal papillary has a papillary growth into the bile duct. Mixed mass forming and periductal infiltrating subtypes account for approximately 25% of ICCs and carry a significantly worse prognosis. So diagnostic workup typically involves ultrasound, CT, chest, abdomen, pelvis, MRI, MRCP, ERCP, and PTC with brushings or biopsy. I do want to highlight, according to the AHPBA expert consensus statement on hilar cholangiocarcinoma, quote, high quality cross-sectional imaging before bile duct instrumentation is the single most important and accurate step in the diagnostic algorithm. The preferred technique is by helical high-resolution CT with at least arterial and portal venous phases with rapid IV contrast bolus. The section thickness should be 2.5 millimeters, reconstructed at 1.25 millimeters. So, key point, Try to get imaging, high quality imaging before instrumentation. I've also added up here the labs, tumor markers, but also colonoscopy and mammography, since these should be performed to ensure that the liver lesion is actually not a metastatic lesion from a different primary location. And then, as indicated in literature, about 30% of cholangiocarcinoma is actually unresectable on exploration. So many authors actually recommend starting with a diagnostic laparoscopy. So the first case that I wanted to discuss is a 66-year-old gentleman who presented to the emergency room with several days of jaundice, dark urine, fatigue, and itching. His past medical and past surgical history are noted above and are really unremarkable. On labs, he had a notable total bilirubin of 12.7, transaminitis, and elevated alkaline phosphatase. This is his CT scan imaging. Hopefully it'll play for you all. And as you can see here, they're dilated intrahepatic ducts. Sorry, I'm going to try to pause it as we go along. And there's an obstruction at the confluence here. Oh, shoot, sorry. Technical error. Oh. I'm going to just let it run. So basically, there's dilated intrahepatic ducts with obstruction at the confluence, and you can kind of see this mass lesion right here. There's occlusion of the left portal vein with atrophy of the left hepatic lobe. So here, the portal vein, left side, right there, narrows down. And then as you can see, there's this hypodense lesion in the left lobe. Fortunately, there's no arterial involvement.
So let's stop over there for just a second. And let me ask John Creasy from Duke, how would you approach this patient?
We have a good quality CT scan, but I do think getting some biliary imaging of the biliary involvement would be helpful. So starting with ERCP and trying to get a biopsy and a good cholangiogram.
Okay, so let's move on and let's show us the MRCP. And once we have the MRCP over here, let me ask John Gary of Providence, Portland, what would you do next with this MRCP? John Gary, Portland?
Yeah, can you hear me? Hello?
We can.
Can you hear me now?
Yes.
No? Okay. I saw that. I just saw it briefly there on the MRCP, but I was wondering if we could go back to it perhaps.
Sorry, the CT or the? Yeah.
The MRCP. So right there, I'm seeing. It doesn't look like the left bile duct is all that visible on that. Looks like the right side is dilated. Sorry, I'm just trying to look at these images. They're kind of coming in sporadically.
Let's go into the MRCP again. So Becky,
but on the CT scan, clearly the left side is quite dilated. So I think the next. Could you please remind me what the bilirubin was?
It was 12.7.
Yeah. So I think the next step then is you mentioned the arterial or the venous involvement of the left portal vein, but you really want to make sure then is that you don't have venous or arterial involvement of the contralateral vessels on the right side, kind of to determine resectability. And then you're going to want to provide them with drainage because that bilirubin is too high. And so we typically would drain what we anticipate the remnant which would be the right side, and you could get brushings potentially that way.
Okay, thank you. So let's ask, so that was the major question over here. So say, Padmanabhan, would you guys routinely drain, or would you just take the patient straight to surgery for left hepatectomy in this case?
So given the size of the future liver remnant being, the right side, the right lobe of the liver, we probably would not drain here preoperatively, just to minimize the risk of cholangitis and other infectious complications. If the situation were that the future liver remnant was, perhaps just a single sector, something smaller, we were concerned and needed to do some sort of pre-op embolization, then we would drain our future liver remnant.
Okay, thank you. And then let me ask Michael Mavros from Toronto, if you did not get a tissue diagnosis in this case, either by brushing or whatever, does that bother you, or would you straight go to the operating room irrespective?
Hi. So I would prefer to have a diagnosis in this case. However, we have staged the patient, right? We have had CTs everywhere. We know there are no meds anywhere else.
Correct.
Well, in this case, it's either probably an HCC or an ICC. So both of them would be treated by surgery. Usually you can tell by the characteristic from the imaging, from MRI or CT. So I wouldn't, I would like to have tissue, but I think we could do the resection.
Okay, thank you. Perfect. Ching Wei, can you just chime in? Do you guys routinely PTC in these hilar lesions?
Yeah, thanks. I think it's a great debate. Our interventional radiologists note that any time a person has a PTC, their average change-out rate is as often as every 28 days, and this is our institutional data. So, I mean, it's a case-by-case situation. If a person is able to get an endoscopic drainage, if they need it, often that's better, but obviously there's risk of pancreatitis. But just, we have to think carefully about PTC. Traditionally, we've done PTC. The answer is yes, we've often done PTCs, but we have to think carefully about it because you buy them cholangitis risk.
Okay, thank you very much. I think just one other point to make is that the nice thing about a PTC is you can sew to a blue tube, which sometimes makes you feel a little bit better. Becky, why don't you go on?
Sure. So we did perform a PTC and put in a PTBD into the right side. The bilirubin ended up decreasing immediately to 7.2. The drain was capped and the patient was discharged from the hospital, seen in clinic 1 week later, and then scheduled for surgery that same week. And at that follow-up appointment, his bilirubin then was 2.6 and his CA19-9 was 1072. And as had been mentioned before, he had a CT of the chest, which was also negative. So then we did go to the operating room, performed a diagnostic laparoscopy, ended up doing an extended left hepatectomy with the caudate lobe, portal lymphadenectomy, and a 3-duct Roux-en-Y HJ. And this is the pathologic specimen over here, and it was a T2B N2M0, 6.5 centimeter, moderately differentiated adenocarcinoma with lymphovascular invasion and perineural invasion. Margins were negative, and there were 5 out of 8 nodes positive. So he's been seen in clinic. He's been recovering from surgery, and the plan is for adjuvant chemotherapy. And actually, I think our oncologists are planning on chemo XRT even after the chemotherapy. So.
Perfect, thank you. I think Dr. D'Angelica wanted to make a quick comment. Jill, can you unmute him? Mike?
I'm unmuted. I'm here with Saker. I just want to make a comment. First of all, there is absolutely no reason you need a biopsy for this at all. There's not a negative biopsy in the world that's going to keep you out of the operating room, and that only serves to increase complication rate. So I think we should already just sort of settle that. There's really nothing you can do to prevent an operation here if the patient's operable. The second thing is, while we all feel more comfortable with drains, most of the data wouldn't support it in a case like this. This is the ideal case to do without a drain. The future liver remnant is huge. You are taking out maybe 10 to 20% of functional liver in a patient like this. And you have to realize when you put in a drain, you introduce bacteria into the biliary system, and most of the data shows an increased risk in this situation. So I understand the technical issues, and I understand the comfort level with, operating on someone who's not yellow. But the truth is, I think it is actually safer in this particular case to do it without a drain. And if there is a case in the world that is right for it, this is the one. It's an atrophic, completely useless left lobe of the liver. There's no obvious vascular issues that you have to deal with. And you can do it in a perfectly sterile biliary tree rather than an instrumented biliary tree. And most of the data shows that if you induce preoperative cholangitis, the risk of that operation goes up tremendously. And that can certainly happen. Qingwei was mentioning the routine exchanges of drains every 28 days. But if this patient gets cholangitis, you've suddenly changed this operation dramatically, not technically, but in terms of their recovery. So I think this is one to consider what to do without a drain.
Okay, thank you. Becky, why don't you keep.
Thank you for that. So I wanted to go over some basic classification schema. There are several of them. Especially for perihilar cholangio, bismuth correlate is depicted here on this slide, and our patient probably had a 3B or a 4. The other one that I wanted to mention is the MSK Blumgart preoperative clinical T-stage that was devised as a clinical staging criteria that basically predicted resectability of hilar cholangiocarcinoma based on preoperative imaging, as we've already been kind of discussing. This staging system stratifies tumors based on local tumor extent within the biliary tree, the presence or absence of portal venous involvement, and the presence or absence of hepatic lobar atrophy. Portal venous involvement was considered present if the tumor contacted and either distorted or narrowed the vein, or if the vein was encased or occluded. Hepatic lobar atrophy was considered present if cross-sectional imaging showed a small, often hypoperfused lobe with crowding of dilated intrahepatic bile ducts. And based on our preoperative CT scan imaging, our patient probably had a T2 lesion. And so there's a study basically of 376 patients who were diagnosed with perihilar cholangiocarcinoma from 1991 to 2008 who had preoperative imaging. Increasing preoperative clinical T-stage reduced the likelihood of resectability by 78% and decreased the likelihood of an R0 resection by 69%. Median survival, including perioperative deaths, was 22.8 months for patients with a T1 tumor, 23 months for patients with a T2 tumor, and 10.8 months for patients with a T3 lesion.
Can I ask a question here? Becky, can I interrupt you for a second?
Please.
So this is a bad tumor, right? You have lots of positive lymph nodes. So it's an ominous tumor. So a question for the group, or maybe you're going to cover this, in which case they can just go on hold, is so if you have some overtly positive nodes on this patient pre-op, or if I make the patient 78, or if this tumor is kissing the artery, the CA19-9 was 1,000 and change, but what if I make it 5,000 and change? Are there circumstances where people here would consider neoadjuvant therapy for a tumor like this?
So let's go ahead and ask. Well, Becky, what did you find when you looked at the data?
Well, that's interesting. So, and I'll probably touch on this, not exactly this, but towards the end when I'm discussing transplant and the Mayo protocol. In my mind, yes, I think there's very likely a role for neoadjuvant therapy.
Okay, let me go ahead and ask Rob Martin. Do you want to comment on that? Louisville? How about do you want to comment?
You there?
Yes.
So yeah, this is Rob Martin. So again, I think that was Brendan who was saying an ominous tumor, and I would agree with him. I mean, this tumor is easily on par with what I would classify as a pancreatic adenocarcinoma stage 2B, to which most people are agreeing to do some form of neoadjuvant therapy. It allows you to assess the biology of the disease, and then more importantly, potentially even enhance your patient selection. So we have started to go more towards neoadjuvant chemotherapy, but most importantly, given that this is a combination of intrahepatic cholangio, is around definitely the molecular staging. I'm hopeful Becky may touch on that, but there are a number of highly targetable markers now in cholangiocarcinoma that really need to be part of our diagnosis because of the actionable treatment options that we have with systemic therapies.
Okay, thank you. Let's keep moving, Becky, because you've got a lot of slides to get through.
Sorry, yes. So, and I'll just kind of try to run through this because I wanted to know what are the latest, survival data basically, and this is one of the most recent ones and the largest series that I found. This is a retrospective review of 402 consecutive patients who underwent curative intent resection from 2001 to 2012 from a single center in Japan, and essentially preoperative evaluation included CEA, CA19-9, CT scan, cholangiogram on all patients. Ultrasound, MRI, PET scans were used selectively. I thought this was interesting. Patients with jaundice or dilated bile ducts in the future remnant lobe routinely underwent biliary drainage, and PVE was performed 2 to 3 weeks before surgery in most patients who were scheduled to undergo an extended hepatectomy, that being defined as greater than 60%. And none of the patients received neoadjuvant chemotherapy. So basically, the vast majority of the patients underwent a hepatectomy with en bloc resection of the caudate lobe and extrahepatic bile duct. Combined procedures, so more extensive, with a pancreaticoduodenectomy was performed in a handful, but not insignificant handful, and then same with vascular reconstruction. Their R0 rates were fairly impressive at 85%, and the R1 resection rates were fairly at 15%. And as you can see here, their overall survival was better following an R0 resection compared to an R1 resection, with 5-year survivals at 48.5% versus 17.7%. And these results are comparable to the MSK 2012 data, where R0 resections were 76%. And from MSK, the median disease-specific survival after an R0 resection was 43.5 months compared to 23.1 months, which, if you look at this graph, is pretty comparable. There, the median survival here is approximately 2 years, and then the median survival for an R0 is between 4 and 5 years. So that just leads me then, I'm sorry, I've like lost a couple pages here, I apologize. So this basically, of the 198 patients with recurrence after an R0 resection, 40% had recurrence within 1 year, 80% had recurrence within 3 years, and 91 had recurrence within 5 years, and the median survival after recurrence was 10 months. So prognostic factors for recurrence-free survival of patients who underwent an R0 resection were microscopic venous invasion and lymph node mets on multivariate analysis, which then leads me to the second study. Oh, the other thing I wanted to point out, so distant mets, so recurrence, so 40% of patients ended up having recurrences as distant mets. So in my mind, so similar to pancreas cancer, I feel like cholangiocarcinoma really should be considered a systemic disease at the time of diagnosis, which then leads to this study. This was a large multi-center American retrospective matched cohort study of 249 patients who underwent curative intent resection of perihilar cholangiocarcinoma between 2000 and 2015 from the U.S. Extrahepatic Biliary Malignancy Consortium. Their R0 rates were a little bit lower at 66%, but adjuvant therapy was given to 57% of the patients. So outcomes of interest included overall survival, recurrence-free survival from time of resection, and patients who received adjuvant therapy were propensity matched to those who did not for variables that were found to be statistically associated with survival, specifically age, ASA, lymph node status, and tumor grade. And based on their data, the adjuvant therapy was associated with increased recurrence-free and overall survival. The median recurrence-free survival was 17.7 months, 10.9, median overall survival 21.5 versus 13.5 months for adjuvant versus non-adjuvant, respectively. This slide here shows their univariate and multivariate analysis. So factors associated with decreased overall survival included lymph node positivity, age greater than 60. Interestingly, tumor size, margin status, ASA class, comorbidities, and concomitant liver resection had no significant association with survival. On multivariate Cox regression analysis, the receipt of adjuvant therapy decreased the risk of death, whereas lymph node positivity, increased age, and undifferentiated tumors increased the risk of death, and those are highlighted here in red. So the key points that I wanted to make regarding perihilar cholangiocarcinoma, basically, as we had talked about, resectability really depends on assessing future liver remnant and ensuring good inflow-outflow bile drainage of that future liver remnant. And as a general rule, we're looking for 20% in a healthy liver, 30 to 35% in a mildly steatotic, cholestatic, or early cirrhotic liver, and greater than 40% in severely compromised liver. You know, this is a whole topic that I think I'll leave to one of my esteemed colleagues to discuss at a future grand rounds. But the other point that I wanted to make is that AHPBA does have a consensus statement that specifically defines bilateral segmental ductal extension of tumor, unilateral atrophy with contralateral ductal or vascular involvement, or unilateral segmental ductal extension with contralateral vascular involvement as unresectable. Before I move on to case 2, are there any other comments?
Yeah, so I wanted to ask, I don't know if we have any transplanters on the line. I know you're going to get to this, but Victor, I believe you've just come off the transplant rotation at OHSC. Tell me, when do you think we should be thinking about transplanting these patients rather than looking at resection? Do you want to give us some insight?
This is Lauren, and I can comment on that. I know most of our patients, I mean, they have to go through the standard workup to ensure that they don't have metastatic disease, but most of them are hilar cholangiocarcinomas is part of it. The other thing is, you know, it's a lot of the other factors based on would they be able to handle transplant, age, things like that. So we've had one patient so far, and he was 50. We have another patient we're evaluating. He's like 36. But it's there's a lot of things that also go into it. So I think if there's a thought that they might be a potential candidate, you should probably talk with a transplant center, because there's things such as you cannot do a percutaneous biopsy, things along those lines. If anyone's actually thinking that they may be a potential transplant candidate.
Right, so that's a good point, and I think, Becky, you'll get to that. You know, diagnosis is not critical for transplant, and in fact, you don't want a percutaneous biopsy. You know, I think the other point about this case is one thing is that this may be a little bit more of an intrahepatic cholangio, since it's a mass-forming lesion that you have, as opposed to a true hilar cholangio that is usually, you know, a smaller but poorly situated lesion. In the interest of time, why don't we go with, actually, let me ask the Hopkins group. Do you have any comments or thoughts? Is Michael Beckman there?
Yes, I'm here. We
Yeah,
had some.
What are your thoughts?
Yeah, I agree with what was discussed earlier. Being sure that there's no metastatic disease and that this is a resectable lesion is important, and being able to resect with an R0 margin is critical.
Perfect. Mike Jacobs, do you have any thoughts or comments? I hope you guys can get through unmuted.
Hi, Lohan, can you hear me?
We can.
Okay, sorry, we were having some trouble earlier. So for me, for us, for true intrahepatic cholangiocarcinoma, we would still favor resection as the best alternative. Now that depends on how extensive it is. Is it truly an intrahepatic cholangiocarcinoma? Is it a hilar cholangiocarcinoma? If they have impingement on either side of the hilar system, in this case, I guess it would be the left side, and it's putting some impingement on the right, we would prefer preoperative drainage, decompression down to a relatively normal bilirubin, in anticipation of, at the very least, a left liver resection with a bile duct reconstruction and Roux-en-Y reconstruction with a fairly extensive regional lymphadenectomy. So for straightforward intrahepatic cholangiocarcinoma, I simply prefer to do just an ipsilateral lobar resection and a regional lymphadenectomy, portohepatis all the way up to the celiac trunk. If during the surgery they have concern of not previously identified periaortic adenopathy, aortal cable adenopathy that was not appreciated preoperatively, we'll biopsy that first and send it off. If it's consistent with metastases, then we would probably back out. And if there's any concern preoperatively, it's one of the areas where I may consider doing a preoperative diagnostic laparoscopy, whereas in most cases I would not do that, even including pancreas, which I know is not the topic of this. So anyway, that's my 2 cents on intrahepatic. The role of intrahepatic cholangiocarcinoma, neoadjuvant therapy. If they have pretty extensive lymphadenopathy along the portohepatis into the common hepatic, then we would recommend giving them a course of neoadjuvant chemotherapy, restage at 3 months, give them more chemotherapy or operate with an intent for operative cure.
Thank you, Mike. One last question. Brendan, can you tell us, sometimes I'm caught with a true, cholangio where I'm unclear as to whether it's going to be a left or right hepatectomy. That's not often, but you have no atrophy. How do you decide on PVE in that patient?
I think that if you have a hilar cholangiocarcinoma that is exactly involving the confluence, a right triseg is a better default operation, a right triseg and caudate than a left triseg for safety and technical feasibility, relationship with the caudate, et cetera. So, I think it's really just about judging technical ease, safety, and a couple of millimeters of duct in either direction. I want to say that in this case, for example, I do not love to do an extended left and have multiple ducts. I prefer to do a left triseg if my posterior sector is big enough to give me a remnant and have one duct. So I think these are technically demanding operations that are high risk, and so it's just balancing the cancer operation, that negative margin, which is a game of millimeters, and really just safety. And I think PVE gets in the mix. So almost always we do a PVE if we're doing a right triseg. So every once in a blue moon, there's a reason to do a left-sided PVE for an extended, for a formal left triseg if you actually happen to have a small posterior sector.
Okay, thank you, Brendan. But I think big teaching points of the fellows, usually that right hepatic artery is involved, and that's why you also need to do a right-sided resection. The left hepatic duct travels longer extrahepatically than the right does. So for all of those reasons, majority of the time you're talking about an extended right to some degree, which is a huge liver resection. You're resecting a lot of liver parenchyma for a tiny tumor. So these are high-risk tumors with the highest mortality of any liver resections we do. Becky, why don't you go on to the next case?
Okay, so the second case, as you can see, a 78-year-old gentleman, he actually had an incidentally discovered mass on CT chest during evaluation for his significant COPD. Before he was seen here, had an MRI and a percutaneous biopsy performed, which showed poorly differentiated carcinoma of pancreaticobiliary or upper GI origin. But he was otherwise asymptomatic. So his past medical history was pretty significant for CAD and his COPD. It had some asbestos exposure and a 75 pack year smoke history. And of note, his creatinine was elevated. CBC, LFTs, coags were all normal. His CA19-9 was 12.1 and his CEA was 4.5. And so his lesion here, you can see I've only got a couple slices of it, showed a 5.2 centimeter lesion. Here we go. Let me stop there for a sec. Oops. Yep. So for him, he ended up getting a colonoscopy and an EGD echo. We had discussed back and forth about laparoscopic versus open because based on the imaging studies themselves, this looked like it would be a straightforward left lateral sectionectomy. And after discussing with our anesthesiologist, ended up just deciding for an open approach, given that his lung function was not the greatest. And he ended up having a 5.6 centimeter moderately differentiated intrahepatic cholangiocarcinoma confined to the hepatic parenchyma. The couple things that I wanted to highlight. So since we did not have a diagnosis of intrahepatic cholangiocarcinoma at the onset, we had resected the left lateral segment. I guess the question is, should we have done a portal lymphadenectomy at the same time? And then what do other people think regarding adjuvant therapy at this point?
So let me ask Abrar Nawawi at McGill, what are your thoughts regarding this case? Abrar, are you on? If not, let's go to Indiana. So Mohammed Tamimi?
Yeah, so if you go back to the CAT scan, please. Okay. So I think it was mentioned that you proceeded to surgery. The question is about performing portal lymph node dissection. And typically we do portal lymph node dissection in those cases. So I will do that in this case. In regard to the resection, I mean, it's emphasizing that achieving a negative margin R0 resection and ensuring adequate future liver remnant, which I assume in this case is possible. There's also a regular contour on the outside of the liver. So was the patient cirrhotic intraoperatively?
No, I don't.
Like the surface
no, not.
Is that so? Just to confirm this finding intraoperatively, was the patient cirrhotic?
Yeah, no, he just had he was not. He did not have.
Yeah, so I think my thought was this patient obviously is a very high risk patient. He has multiple comorbidities, but in general, it seems that the lesion is resectable, and then doing portal lymph node dissection should be part of the management of these cases, or at least this is what we do.
Okay, well, let's keep moving, Becky. So.
Okay, sure. So again, I wanted to highlight there is an AHPBA consensus statement on intrahepatic cholangiocarcinoma, and I've tried to hit on some of the key points that are emphasized in that statement. Biopsy is not necessary if the surgeon suspects intrahepatic cholangio and is planning curative resection, like we were. As I stated before, the patient had already had a biopsy, but it is not necessary. And if the biopsy shows adenocarcinoma, an occult primary tumor should be ruled out in most instances, unless immunohistochemistry and imaging are clearly consistent with intrahepatic cholangio. Just as with peri-Hilar resectability, as Mohammed was mentioning, resectability is defined by the ability to completely remove the disease with curative intent, i.e. R0, while leaving adequate liver remnant. Extrahepatic disease, multilobar or multicentric tumors, and lymph node mets beyond the primary echelon are formal contraindications to resection. And yes, lymph node, regional lymphadenectomy should be considered as standard part of surgical therapy for patients undergoing resection. At the time that this statement was written in 2015, there were no randomized studies suggesting that adjuvant therapy in margin negative or no negative ICC should be given, but resected margin positive and node positive intrahepatic cholangiocarcinoma systemic therapy with either gemcitabine or 5-FU or 5-FU based radiation should be considered. And cisplatin plus gemcitabine represents the standard of care for metastatic intrahepatic cholangiocarcinoma. And I just wanted to go over the BILCAP trial, which came out last March, I believe, and this was a phase 3 RCT in 44 HPV centers in the UK, comparing 8 cycles of capecitabine versus observation in resected cholangiocarcinoma and gallbladder cancer. 447 patients were randomized from 2006 to 2014. Please note there was a per protocol analysis and an intention to treat analysis that differed by 17 patients, and that's down here. And I'll discuss the importance of that in just a sec. So this slide here describes the study cohort. Note that there's heterogeneity of the cancers with approximately 20% intrahepatic cholangio, 30% were perihilar cholangio, 35% were distal cholangios, and 15% were gallbladder cancers. The R0 resection rates were about 2/3, which was similar to the US Extrahepatic Biliary Malignancy Consortium, and there otherwise were no real statistical significant differences between the two groups. So the take-home point, So by per protocol analysis, the median overall survival was 53 months in the capecitabine group versus 36 months in the observation group. Unfortunately, that was not statistically significant in the intention to treat analysis. The other thing that I actually wanted to point out from the study is that 55% of patients completed in the capecitabine group completed the 8 cycles of therapy. 46% had at least 1 dose reduction. 44% had at least 1 grade 3 toxicity, the most frequent of which was hand, foot, mouth syndrome, diarrhea, or fatigue. And 32% had to discontinue treatment due to toxicity. Now, the reason that I mentioned this is because we as surgeons often think of surgery as a big insult to the body, but chemotherapy is also not necessarily well tolerated either. So then the question remains as to what is the most effective sequence of therapy for these cancers. One of the limitations of this study was a long recruitment period over 10 years, which adds a significant temporal component to all of it. And what I mean by that specifically is that over the past 10 years, surgery, medical management, the oncologic therapy has changed and evolved. So the question is, are these differences that we're seeing the result of the temporal changes that have occurred? And then the other big limitation of this study is the heterogeneity of the biliary tract cancers that's included in this study, which makes the overall interpretation of these survival curves that much more difficult. But the take-home point that I want to make here is that adjuvant therapy with capecitabine is likely beneficial in resected biliary malignancies. I'm going to go quickly. Actually, I'm going to skip this one because I sent this article. You guys should have a copy of. And I just wanted to touch briefly on transplant for cholangiocarcinoma. There was a lot of data. Basically, the early survival data following transplantation for cholangiocarcinoma was really dismal. However, with improved chemoradiation and stringent screening protocols, the survival curves have actually improved, mainly from pioneering work from Mayo and University of Nebraska. This study here is basically a series from Mayo, basically from 1993 to 2008. 167 patients were entered into this protocol that's listed up here. 12 patients died or dropped out during the neoadjuvant chemotherapy. 111 patients underwent liver transplantation, and the 1, 3, 5-year patient survival after transplantation was 96%, 83%, and 72%. With a 14% recurrence rate at a mean of 25 months after transplantation. So, I mean, those are significantly much better numbers compared to the others that from the survival curves that I showed you before. So, more recently, this study, transplant versus resection for Hilar cholangiocarcinoma, has come out, and this again was based off of data from the U.S. Extrahepatic Biliary Malignancy Consortium, and showed improved overall survival with transplantation versus resection. So 191 patients underwent curative intent resection, 41 patients underwent curative intent transplant using the Mayo protocol, and the patients who underwent transplant had improved overall survival compared to those who underwent resection. 3 years was 72% versus 33%, and at 5 years, 64% versus 18%. The criteria for transplant, as we kind of touched upon, is actually fairly small lesions, so they had to be less than 3 centimeters, lymph node negative, and pre-transplant neoadjuvant chemo XRT followed by chemotherapy until the day of transplant. And so, you know, this was kind of touched upon. The question is it the transplant, is it the neoadjuvant therapy, the selectivity of the patients, and the tumor biology that really makes for improved survival? Any thoughts from the group?
So do we have any transplanters in the group that can comment? I'm not sure that we have any on.
No,
this is Jake Hartman. Mayo, if you want us to.
Please, that would be great.
Generally these patients are evaluated by both groups, generally at the same time. For the Hilar cholangios, there's a protocol that's going to be initiated for very small intrahepatic cholangios, but that's investigational only. Even here, with the extensive experience with transplant for Hilar cholangiocarcinoma, if a patient is resectable, they go to resection. If we think they're resectable, they go to resection. So these are very highly selected patients. Unfortunately, some of the patients will fall off. If there's positive nodes in the area that we're going to operate, they're out of the protocol, and so we would resect if we can. The thought process is, in terms of the local control rate, it certainly is the radiation therapy. The doses are given in such a way that if the patients then fall off and don't go to transplant, they will eventually die from progressive liver failure, typically radiation-induced afterwards. So it is a very, very heavy dose of radiation locally from that standpoint. So when you look at the overall survival intention to treat, it drops closer to resection, and so that's why, from our standpoint, we generally would resect if we can.
Just a technical question from a transplant standpoint. Because of these high doses of radiation, do you guys jump with cadaveric vessels rather than using native hepatic artery?
They don't always, but they follow the patients are followed on a protocol, an imaging protocol, very closely postoperatively, every couple of months for the first year because of the risk of pseudoaneurysm and arterial stenosis.
Perfect. Thank you very much for those comments. I also believe that as part of the transplant protocol, most people would do an EUS-guided biopsy, some centers of the station 8 node, and try to ensure that there's not any nodal disease as part of this pre-op staging or a laparoscopy or something to that degree. Are there any other transplanters on the call that can comment? Okay,
It's like, I'm not a transplanter, but one of the things that comes up more frequently than we care to admit is the lack of the patients being able to get to transplant centers for some of these conditions. So being in Detroit, the population of some of these patients doesn't permit them to even be offered for a liver transplant. So let alone to take all the therapies and the office visits and things like that for the post-transplantation surveillance and measures and things like that. So there's definitely a disparity, in this situation. So if we encounter this in the presence of somebody who has underlying cirrhosis of the liver, not from the tumor per se, but just underlying cirrhosis, where they have decompensated disease, say Child's B, C, definitely we would refer them for liver transplantation. But in part, it's the disparity that the patients experience that we keep them in their home hospital and operate on them when appropriate.
I should also make a clarification here from Mayo is that we see a large PSC population, and so the outcomes in PSC are far exceed those in de novo. And for PSC, the answer is transplant. Generally, the ability, while we do it very, very occasionally in patients who will not meet transplant criteria, the outcomes are poor, and those patients don't do well generally with resection. And so for PSC patients, it is always transplant. For the de novos, we try to resect if we can.
And of course, Mayo came up with the PSC risk stratification for cancer. So I think that algorithm also helps. Well, thank you, Becky. Thank you very much for a great presentation. Just big points: extrahepatic or Hilar cholangiocarcinomas. Obviously, think about transplant, think about resection. Most commonly, you're talking about an extended right resection. The controversy over drainage recurs. The Japanese drain very aggressively. Many centers in the US do not. The controversy is around use of portal vein embolization for major hepatectomies. Again, you're mostly talking about a right-sided PVE, as Dr. Visser talked about. You talked about the adjuvant treatment algorithms, as was pointed out, and a high need for those. And then with the intrahepatic cholangiocarcinoma, you talked about resection as the gold standard with lymphadenectomy, and then the question as to whether adjuvant treatment needs to be given, and you presented data to support that. Thank you very much, Becky. Brendan, I think you wanted to make an announcement.
Yeah, quick comment. Becky, that was terrific, Dr. Kim. So the next call is March 11th. We're pushed back a week because of the AHPBA Congress, and I will look forward to seeing all of you guys there in Miami. Wash U will be presenting, and UPMC will be moderating that. In an attempt to continuously improve the content and quality of the conference as our main teaching conference, the fellows will be receiving shortly a very short survey with the help of Dr. Tara Kent and the Education Committee. Just a handful of questions, just trying to get some feedback so we can continue to improve and make this a worthwhile venture and time for everybody. We know we're pulling you away from clinical work and other opportunities. Thanks so much to everybody.
Thank you very much, everyone.
Thank you.
Have a good night.
Thank you.